I take this opportunity to welcome the team from Central TB Division, NTI Bangalore and NIIT Chennai. A very warm welcome to all the state TB officers, directors of STDCs, district TB officers, participants from medical colleges, and we have Dr. Ashok Bharadwaj with us, Chairman NTF. A very warm welcome to everyone, all the participants. From today, we are starting a series of difficult to treat TB clinic, wherein the states will be invited to present their case and discuss them. First in the series is state of Uttar Pradesh. A very warm welcome to UP team and congratulations to take this initiative. A round of applause for the UP team. A very warm welcome to State TB Officer of Uttar Pradesh, Dr. Santosh Kumar, Deputy STO, Dr. Rishi Saxena, expert for the case, Dr. Suryakant, and presenters of the case, Dr. Darshan and Dr. Nandini. I also welcome and thank DTO Lucknow, Dr. Kailash Babu, and Director STDC, Dr. Bharat Bajaj. A very warm welcome. Today is also a very special day for us as we celebrate our 66th Founders Day. Today our institute was established. So we complete 66 years today. So we congratulate the NITRTB team for that. And now I request Dr. Rupak Singla to give the introductory remark. As our director, Dr. Diwan had to go in for a surgery. He got a call from the OT and he had to leave for that. So over to you, Dr. Rupak Singla.
Thank you, Dr. Neeta. A very good afternoon to all the people who are participating today. And as you are aware, we have been running this difficult to treat TB clinic for last 1.5 years. And when we started this clinic at the national level, we had an aim in mind that one day all the states should have their own state level difficult to treat TB clinic. And I feel very proud and happy to announce that today 26 states and union territories have already started. And we hope in the next 3-4 months, more and more states will be joining it. And it's a matter of pride also that for UP, they are running their state level difficult to treat TB clinic not once a month, but twice a month. So I think let us give them a big hand for this also. Now, any new initiative, you know, it's easier to start, but to sustain is difficult. But UP has proven that they can take any challenge which is given to them. So, and last time it was announced that from this time onwards, the states will be presenting their difficult to treat TB clinic, and which will be discussed at the national level. So today is the first day when state is presenting the clinic, and it is being discussed at the national level. I congratulate the entire state team, the STO, Deputy STO, STDC Director, the STF Chair, all of them I congratulate for taking this initiative that they have opted as the first state to join in this national level clinic. With these few words, I look forward for a very interesting case discussion today. Over to you, Dr. Neeta, please.
Thank you, Dr. Rupak. Now I request STO UP, Dr. Santosh sir, to give his introduction to his clinic.
Good morning, sir. Good morning, Mrs. Singla, madam, and good morning, all the participants. This is Dr. Santosh Gupta, STO UP, and as mentioned by Professor Dr. Rupak Singla, that UP started its difficult to treat TB clinic on 30th June 2021, and we have already conducted 18 difficult to treat TB clinics, and it's our privilege to present the case at the national level. Our STF chairperson, Professor Suryakant, is moderating the session as the guest faculty also. And I'm thankful to Professor Rajendra Prasad ji, National Vice Chairperson of NTF, and Professor Rupak Singla ji for supporting the state in this initiative. This initiative is largely being taken care by the STF, and from STO office, Dr. Rishi Saxena, Deputy STO UP, is the nodal person for this activity. So I am handing it over to Dr. Rishi Saxena to elaborate further regarding difficult to treat TB clinic in UP. Thank you very much for giving me an opportunity to speak at this moment. As we are having a meeting at Raj Bhavan regarding World TB Day celebrations, so I would request the panel to exempt me from the further discussions in the TB clinic. Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir, and respected esteemed faculties, national faculties, and DTOs, HODs, and all. It's a privilege that UP has been given a chance to present a case. The difficult to treat clinic is intended to serve as a national and a state level clinical decision support system and an avenue for capacity building of nodal district and DRTB centers in the states of India in good quality management of difficult to treat TB patients, as well as experience sharing and learning through local available virtual platforms. Besides this, it is improving the quality of the clinical care provided to DRTB patients under the program and eventually improve the quality of life with better chances of treatment, success, and survival. With this, I hand over to Dr. Darshan Bajaj, who will be presenting the case today. In fact, her resident will be Dr. Darshan Bajaj will be coordinating, and the resident Dr. Nandini will be presenting the case. Over to Dr. Darshan Bajaj.
Thank you, Dr. Rishi. So before we go for case presentation, I would like to introduce the faculty who's with me. On my right is Dr. Rupak Singla, who's head of the Department of TB and Chest, and he's the national expert today. On my left is Dr. Amitesh Gupta. He's a specialist with us for TB and chest, and he will be helping me in coordinating this clinic. I am also supported by a team from ECHO India, Mr. Prateek, Mr. Ankur, and Mr. Manjeev. And the case presentation will be done by KGMU team, Dr. Darshan Bajaj, who's the additional professor and Department of Respiratory Medicine, and Dr. Nandini, who's junior resident in the same department. Expert for the case will be Dr. Suryakant. Dr. Suryakant, sir, yeah. So everybody can see Dr. Suryakant. He needs no introduction. He is professor and head Department of Respiratory Medicine at KGMU Lucknow. He has more than 700 publications and has more than 26 years of experience in treating tuberculosis. And we have national expert Dr. Rupak Singla for the case. So over to you, Dr. Darshan Bajaj, for presentation of the case.
Thank you, ma'am. And thank you, Dr. Rupak Singla. Before I hand over to Darshan, I just want to welcome and, of course, present my thanks to the NITRD for including our department on this wonderful platform first time. So this is a great and a very auspicious moment for the Department of Respiratory Medicine. And today, all of the faculty members and most of the residents, except those who are in emergency duty or in OPD, they have logged in this program. And as you have already heard, the state TB officer, Dr. Santosh Gupta, and his deputy, Dr. Rishi Saxena, is already there. And my teacher, and I think teacher of most of us, Dr. Rajan Prasad, has already logged in that, who was earlier head of department of department. And today, the only problem is because we have recently developed this ecosystem, and today some problem is there. So I think this ecosystem is not working properly at our site, and Gaurav, who is in charge of this technical affair for this from the Eco India team, so he's not here in the city. He has some family problem, some medical problem in the family member, and that's why he's not here. So I'm sorry for that. Anyway, next time will be with wonderful background of eco and everything. So this is my request to the all those who are representing the Eco India on this platform, that please, of course, as we are the beginner on this platform, so I think you should instruct your team that they should represent here at least in some initial programs. So with this, I'm handing over to Dr. Darshan Bajaj, who is the main hero of this today's program, and Dr. Nandini, who has, of course, beautifully presented this case. So Dr. Nandini is junior resident 13 in our Department of Respiratory Medicine. And our all colleagues, Dr. Kushwa is here, Dr. Ajay Verma is here, Dr. Jyoti is here. And I think they have logged in from their own mobile or computer or laptop devices. So over to Dr. Darshan Bajaj.
Thank you, respected sir, for this wonderful opportunity to present this case on the national platform. So we have divided this case into two parts. First, Dr. Nandini will be presenting the case, and then myself and Suryakant sir will be trying to solve the case. So a lot of my teachers are here, a lot of my mentors are here. Warm greetings to everyone from my side. You may have trained me somewhere on this. Singla sir means whatever we have learned in PMDT guidelines, it is because of Singla sir and how to design a regimen. Since the 17 guidelines, Singla sir has been training us on various platforms, sometimes physically, sometimes online training. So many of the things I have learned from Singla sir, how to treat these PMDT, these DRTB patients. So now Nandini will be presenting a case, and then myself and Suryakant sir will be trying to solve the case to the best of our knowledge. So Nandini, please.
Are my slides visible, sir?
Yeah, Nandini, they are visible. Can you put them on slide mode, presentation mode?
Ma'am, I've already put that. Is it visible now?
No, the mode is not visible. Your slides are visible.
Just a minute.
I think your connection is a little slow. No problem. Just take.
The video can be off.
Is it visible now, sir? So are my slides running?
No, they are not running. Please share your screen again. Screen. Yeah, perfect. Perfect, Nandini. Perfect.
Just a minute, ma'am.
Yeah, Nandini, they are visible. You can start the presentation.
A very good afternoon to all the dignitaries present on this beautiful platform for a discussion of a difficult to treat DRTB case. I am Dr. Nandini and will be presenting the case today. So this is a case of a 41-year-old male who presented to our side with complaints of fever for 2.5 years, cough with copious expectoration for 2.5 years, breathlessness on exertion, which he has recently pursued for the past 5 months, and persistent weight loss and appetite loss. So we are seeing by this case history that this person is not getting clinically improved for the past 2.5 years, and his symptoms are persisting for the past 2.5 years. This patient had no history suggestive of type 2 diabetes mellitus, systemic hypertension, or any other known comorbid condition or an immunocompromised state which will be responsible for his worse outcome. Patient had no known history of close TB contact. The patient had already received treatment for drug-sensitive tuberculosis on multiple occasions for nearly 24 months with no signs of either clinico-radiological improvement, neither there was microbiological conversion. Patient was taking this treatment for the past 24 months and was referred to our side in February 2022. As we can see in his progressive radiologies that are shown on these subsequent slides, we are seeing no radiological improvement, and on the contrary, we are seeing radiological deterioration only. This is his latest X-ray, and this is his CT scan, which is done on 11th March 2022 this year as only. So this is the detailed ATT history of this patient. This patient was diagnosed as a case of pulmonary tuberculosis first time in 2 years back, in February 2020. He was diagnosed on the basis of a sputum smear examination, which was 1+2+ positive, and was started straight away on a drug-sensitive TB regimen. He took that treatment for 9.5 months with full compliance, and he was not failing on ATT. Then also there was no radiological or clinical response in the patient. After taking a 9.5 duration of first line ATT, he had no response, and his sputum sample was again subjected for smear analysis, which again came out to be 2+ positive. Suspecting him to be a DRTB case, the DOT Center at Amity sent a sample for CBNAT analysis, which unfortunately did not detect any resistance at that time. His sample were also sent to KGMU for first line LPA and second line LPA testing, which also showed that the sample was sensitive to first line drugs and was having isolated quinolone resistance. Since this patient was not qualifying to be a case of a DRTB, he was continued on first line ATT for as long as 24 months. On different occasions, his samples were sent for CBNAT analysis, and on no such occasion did we detect a rifampicin or H resistance in this patient. This patient, these are the reports that I have shown. This was the first CBNAT which was done in December 2020 after 9.5 months of first line ATT. This is the LPA report which was done on 4 different occasions in February 2021, in July 2021, in December 2021, in February 2022 as well. All the reports were consistently showing R and H sensitivity and isolated quinolone resistance, which was on the Gyre A loci. Mu3C was present, so he was not even sensitive to high dose moxifloxacin. His culture that was sent in February 2021 was positive, and it was also showing quinolone resistance. However, at that time, DST for first line drugs was not applied, so that report was not available with us. His culture sent from our side in February 2022 was also positive, and its DST is still available. These are the reports of the first line, second line LPA, which was done initially in February 2021. This is the report of isolated quinolone resistance in his first culture that was sent to KGMU from Amity. And this is the current LPA report, which is showing Mu3C at Gyre A loci, which means isolated quinolone resistance in second line LPA, and HNR sensitivity in first line LPA. So since this patient has no response to DSTB treatment, he was tested for drug resistance via CBNAT and LPA multiple times. But on no such occasion, drug resistance was established. So he was continued on a DSTB regimen. His first line LPA also showed absence of HNR resistance. In view of his deteriorating clinical conditions, his sputum sample was subjected for whole genome sequencing. And this was the very first time when drug resistance was established in this case. And then the patient was referred to our side. This is the report of the whole genome sequencing done in 13 December 2021, which shows resistance to all first line drugs, as well as resistance to quinolone and amikacin and kanamycin. And this is the sensitivity pattern of the whole genome sequencing. It is sensitive to bedaquiline, delaminid, clofa, pretominid, PAS, linezolid, and ethionamide. So according to this report of whole genome analysis, this patient is now a pre-XDR. So this is a case of a 41-year-old male patient who is not improving on DSTB treatment and is having a disparity between the reports of NAT, LPA, and WGS. The patient clinically appears to be a case of drug-resistant TB, and DRTB treatment seems to be a more reasonable option for this patient, but CBNAT and first-line LPA are not showing any evidence of drug resistance. His liquid culture sent in February 2022 is positive, but this DST report is available. So these are the points on which this case requires discussion. Till his DST reports are retrieved, it's a matter of discussion that whether this patient should be started on a DRTB regimen or not. That whether we should give weightage to the whole genome sequencing report or not, looking at the clinical profile of the patient. If at all this patient has to be started on a DRTB regimen, what will be the ideal regimen for this patient, a BPAL regimen or a modified all-oral longer regimen? Because this patient is sensitive to all the 3 drugs used in BPAL, that is bedaquiline, pretominid, and linezolid. Whether there is a possibility in this case for coexistence of NTM and MTB. Is surgery an option for this particular case? And if it is, at what point of time? And can isolated quinolone resistance exist in R and H sensitive patient? And then what is the nomenclature for such patients in that case? With this, I thank my mentors, Dr. Suryakant and Darshan Bajaj sir, for giving me such a wonderful opportunity to present the case on this background. And now over to sir for further discussion. Thank you so much.
Thank you, Dr. Nandini. Before we take the discussion on this case, we would like to open the case to our audience. if they have any questions regarding the case history till this point, whatever Dr. Nandini has presented. Dr. Nandini, there is a question they are asking, is there any history of malabsorption?
No, ma'am, there was no history of malabsorption. Patient has absolutely no GI symptoms.
Okay, thank you. So those who have just joined, it's a case, a 41-year male who has been treated for drug-sensitive TB for 2 years and was not responding to treatment. And patient was clinically and radiologically deteriorating, and sputums done over time. The CBNAT has shown RIF sensitive, but FQ and also FQ sensitive. They have a LPA report also where there is resistance to fluoroquinolone, but sensitive to second line injectable. And then they have a WGS report, which is showing resistant to all first line drugs plus fluoroquinolone. So basically their issue is that there is a discrepancy between the LPA report and the WGS. So if there are any questions pertaining to the case history, we can take it. Yeah, there is one question on the chat.
There is one question that whether TDM therapeutic drug monitoring was done in this case, serum drug levels.
No, therapeutic drug monitoring was not done in this case. Was never done in this case.
So I think
Dr. Nandini, was DST for linezolid and paraxine was done
Sir,
before?
we have sent it from our side because this patient came to our side in February 2022 only. We have sent his CBNAT, we have cross-checked his CBNAT report from our side also. We have sent his LPA, which is showing a similar pattern of resistance. And his culture is positive, which we have retrieved the report few days back only. So we have sent it for DST and its report is awaited.
And no other previous DST, hello?
Yes,
And
sir. Yes, sir.
Nandini, no other previous DST was available, phenotypic DST?
Sir, only one report was available, which was quinolone resistant. So we
Which was only
about,
showing quinolone resistance,
yes,
and
sir.
they are sensitive to all other drugs.
No, sir. First line was not available. That was not done at that time. Only second line.
First line was not done at that time.
Not done. Yes.
Okay. And what was the lab? It was the KGMC itself.
KGMU lab, sir, we had informed about this case why first line DST was not done. So they told us when a case is generally sensitive in CBNAT, they generally don't apply it for first line DST. It's not the part of a program.
Okay.
Yes.
Nandini, there is a question they're asking whether culture for NTM was sent or not.
And we have sent it from our side.
But you haven't got it.
But recent update that we have got from microbiology is said that its NTM is not present. It's not grown.
Okay.
And additionally to that, ma'am, I have also inquired from the whole genome sequencing lab, and they have mentioned that even whole genome sequencing can detect NTM coexistence. So they are also confirming that there is no NTM in this case.
Okay. And there is a question, what exactly is whole genome sequencing?
Ma'am, whole genome sequence, in normal.
Maybe I think we'll ask one of the microbiologists. We have Dr. Ritu with us. She's our senior microbiologist at our institute. Dr. Ritu, can you tell us something about whole genome sequencing?
Actually, I was before we go to whole genome. Actually, I wanted to ask one question. I would like to see the report of your thyrocare, because we have seen the earlier reports also. With due regards, thyrocare is a great lab, because whole genome is nothing but a it's a sequencing of the entire genome. The problem is not whole genome sequencing. The problem is the quality. If it is not done in a proper quality way, if the interpretation has not incorporated all the mutation and all the genes, it may really become very difficult to interpret, and the interpretation may sound very logical, but it may not be. So can you just show the report again of whole genome?
Thank you, Dr. Ritu. So now
we will just show you the report again.
Yeah, we want to see the report again.
Ma'am, this is the report, ma'am.
Can you just maybe just put it on a one-pager thing because really
Just a minute, ma'am.
इसको कैसे लाते हैं?
the report in which they're showing the SNPs, the mutations.
Ma'am, we are trying to enlarge it. Just a minute. Ma'am,
So actually, just wanted to highlight this aspect. Whatever.
I'm just mentioning the fact that the frequency of all the mutations was very high, and on all the mutations they have confirmed that there is high level of confidence for detection of mutation in this case.
So have they mentioned that what have they referred, what method of
Yes, ma'am, that's mentioned. I can we can separately send you a picture, ma'am. It's not getting enlarged over here, but they have mentioned what they have done, and they have said that it's in high frequency.
And also something which is
So, ma'am, at this point of time, I will like to frankly tell you that we have only a handful of experience with such kind of patients. Only 2 or 3 patients we have experienced this kind of whole genome sequencing in our career till now. So, because we are not very well versed with the whole genome sequencing, so means we have brought up this case in this discussion only. That is the reason why we have brought up this case, because there was a disparity between the traditional genotyping and the whole genome sequencing. And we personally don't have much experience with the whole genome sequencing.
So,
Dr. Darshan, please go. During her presentation, Dr. Nandini has shown the mutation pattern of the whole genome sequencing. Please show that. Dr. Ritu will be commenting on that. So please go down. You have shown the whole genome sequencing report and the mutation report also. So because that is very vital for discussion. So can you scroll down?
Can you see the slides, sir?
Yeah, this slide can be seen, but this is not a whole genome sequencing. This is
what we have.
You need to reshare. Maybe stop the screen share and start it again, and you'll be able to share it.
Dr. Rupak.
Yes.
Dr. Rupak, I'm Dr. Surikant.
Yes, we know you very well.
Actually, we have also microbiologists in our group. Dr. Parul Jain from the microbiology department, King George Medical University. She is also logging. So we can have the opinion from Dr. Parul also.
Sure.
Actually, this genome sequencing report is not from our institute. This is from private institute, ThyroCare. So I don't know what is the status of ThyroCare. You can tell me better.
That is what actually. Good afternoon, sir. This is
now you can see the whole report. This is on the screen.
Yes, sir. Sir, what we were trying to say is
Dr.
that...
Ritu, can you see? Dr. Ritu, can you see?
Sir, I can. Thank you so much.
Okay,
I can. So, sir, I just wanted to just highlight one thing, that all these things are fine. But what is very important to know is that were all the quality procedures used? Was it, done as per the WHO defined standards? Because, the labs, which are our labs under our IRL and the CTD network, we are following certain quality ensured procedures before we are able to comment. So any whole genome sequencing we can do, and we can generate a report, but the quality is very important. We may be missing, or we may be falsely saying it's a possibility. So that needs to be really asked from the lab and ensured before we are able to use this for patient care. That is my only apprehension, sir.
Yeah, thank you, Ritu. So
Dr. Ritu, this is wonderful opportunity for learning for all of us. Can you brief how can we judge the quality of report of whole genome sequencing?
So for this, as a clinician, it will be difficult, but you can ask them for the Q30 parameters. There are something called as Q30 and other parameters on the particular FASTQ format, or there's a program on which you can see all the Q30 parameters. So ask them to share at least, that will put a pressure on all the labs that yes, these needs to be in order before we are able to generate the lab. Because right now, what you are given is the output. You've been given that this is a mutation here, this is resistant or sensitive. So at least, and you can just get it verified by another person, microbiologist within your institute, or somebody else who is able to comment. Dr. Meeta ma'am is also there from your institute, sir. And I think she will also be really able to help you out in this. or if you want, you can send it to our department.
Yeah, thank you, Ritu. So what I get from what you are saying is that right now it is not a acceptable test for our program. Though in private sector they are doing it, but right now it is not recognized by our this thing. And I think the program will do quality checks and will, once they are satisfied that this can be taken as technology, then it will be considered in the program. But Ritu, just for our audience, can you tell us in very short what exactly is this test? What do you see other than LPA in this test? Or why is this test being done?
That's a wonderful question. So why this test came into being is, now I want you all to visualize that, let us say INH. Let's talk about an antibiotic INH. So INH currently, by LPA, we are seeing through two genes, right? CATG and INH. Now that does not mean that there are not other genes which are causing INH resistance. There are other genes. There are close to 5-6 genes. So when we are saying whole genome, means it takes the entire genome of MTB and it will cover and scan the entire genome to find out if there is mutation in the whole genome. Whereas in the case of LPA, what they do is they will take only 2 genes, and in that 2 genes also they will take a small portion. So let us say they will only take your about 81 base pair for RPOB, whereas in the case of whole genome, it will take your 2200 bases. Entire thing will be taken. So obviously the sensitivity becomes much more, but with that comes a problem of quality, because you may also be getting something which is reported as SNPs, which may not be causing resistance. Maybe Q30 is low, maybe some segment is deleted, and we really need to go into that. So that is the meaning of whole genome. One is a small segment in a particular gene, that is LPA for you, and one is complete entire segment of all the genes across all the antibiotics. What is key is the quality of whole genome that is done. Secondly is the quality of the data analysis. Both have to be perfect. I hope that answers your question, ma'am.
Yeah, Ritu. I think it's very nicely explained. I think we can open this case for discussion now. So over to Dr. Suryakant sir for discussion.
So ma'am, now we will be going to the second part of this presentation, that is our discussion. So as you can see this, we brought up this case because there's a disparity between the...
Neeta, may I come in for a moment?
Sure, sir.
Actually, the group who has done this focus, TV focus, what they say, this is, I know this group, and I think Dr. Rupak Singla is also with me in that particular group. They are IIT Mumbai group, and they are doing all research work with the Bombay people, like Bombay macrobiologists, very, very known people. And they have a lot of publications. So, and they have approached the government also for the approval of doing gene sequencing. So that group is, to my extent, to my knowledge, they are doing a lot of work. And actually they are from England, and now they are the IIT Bombay group, and they have developed a lab, and they are doing gene sequencing with the Bombay group people, and they have some publication also. Quality, of course, we have to ask, but they have also reached to the CTD for their approval, and I must hope, Rupak Singla, you are in the same group, right?
Yes,
yeah.
Have you finished? Have you finished? Yeah.
This report is by the Haystack Analytics. They have now the collaboration with, I think, this ThyroCare at present.
Okay, sir. Thank you. Thank you for your comments. Actually, the whole concept of whole genome sequencing, the NIRT Chennai under Dr. Padma as director, they carried out a four days workshop focusing on the whole genome sequencing, because it is for sure that this is an upcoming technology. And
yes.
And in our PMDT 2021 guidelines, there are 2-3 pages devoted to this. But at the same time, in the workshop, what was discussed, that whatever the existing labs are reporting for the whole genome sequencing, they are using the WHO catalog. So the sequence of mutation, what is being reported is from the WHO catalog, and the Indianized version, that is whatever mutations we are having in Indian patient, that is still missing. So that is one part. Secondly, what was discussed in the workshop was that once the entire genome has been sequenced, then the interpretation of the report. So the interpretation of the report also needs a software which should be focusing on the genes which are could be there in India, which could be different than the WHO sequence. That is another thing. And third is, of course, like Dr. Ritu emphasized repeatedly, about the quality check. So I think this is a national forum. So very clearly the message should go, yes, it's upcoming technology, and we are looking forward for this technology, but at the same time, we need to do little more work. And the NIRT Chennai has taken a lead in this context, that they will be developing this sequence as well as the interpretation after the sequence has been seen. So plus the quality check. So we need to keep in mind that we have to wait for that before we start treating the patient based on this.
Yes,
The information is good. Yeah. So I think, sir, you will agree that before we start taking a treatment decisions, we need to wait for some time.
I totally agree with you. Yes.
Okay, that's all I wanted to convey at this stage. We'll come back again.
Quality control is a very important issue for any lab test.
Yes, sir. Go back to the discussion. We'll come back again on various other issues as well, which are there in this.
Yeah, sir, it's on my personal opinion and as a state level officer. So if we focus on the taking correct proper detailed history, send send samples adequate and in a timely manner, and with proper transportation on time, whether it is diagnostic or follow-up, and monitor turnaround time of lab reports of CBNet, FLA, SLA, LPA, DST culture, then I think the results of this test will be at par with WHO's report, and it will also be cost effective in the current scenario as compared to the WGS. I hope all the lab personnels, NRLs, IRLs would agree in this case, ma'am.
Since you have opened up this discussion, like if you are faced with such a case, first of all, ensure the compliance, which we were told that the patient was compliant. Secondly, the moment we find that 3, 4, 5 months are over and patient is not responding, and the laboratories are saying he is sensitive, so we should do the blood levels. We know that there are limitations to blood levels, but then there are institutes which are doing it, like NIRT Chennai is doing it, in AIMS they are doing it. So even we have tie-up with these institutes, we can also help in doing the blood levels. So we must see whether the person is absorbing the drugs or not absorbing the drugs, and accordingly we need to take a call. Secondly, as Dr. Rishi said, we must ensure that timely collection of the samples, a good sample for CBNet, good sample for LPA, first hand LPA, second hand LPA, that should also be collected. And then we need to see that what we can do to the patient. But at the same time, basic dictum of treatment is that once patient has taken treatment for 6 months or more and has not responded, whatever the lab may be saying, but we need to treat the patient as a drug failure case. Treat the patient as a drug failure case, and we need to change the treatment regimen. So we'll come on these issues once. Let us see. Dr. Suryakant is the expert for this case, and we'll come back on these issues, how to treat this case. So I'll request Dr. Suryakant also to give his opinion on this case. Dr. Suryakant, please.
I couldn't hear actually. My device is. मेरे device पे sound नहीं आ रही है. Hello.
Okay, can you hear now?
Yes.
Okay.
Yes.
What I just said was that in these cases, whenever patient has taken treatment, say for more than 6 months, 7 months, and is not responding, we should do the blood levels. And even if the blood levels are saying it is normal or it is reduced, definitely the treatment needs to be changed. Now, what treatment and all, that is the discussion number 2. So before we go further, as an expert for the case, I request Dr. Suryakant to give his opinion about in this context also. Could you hear Dr. Suryakant? Could you hear whatever I said? I think his connection is anyway. Till he joins back from the audience, anybody can comment on this issue. That once the patient has taken treatment for say 6, 7 months, 8 months, still smear positive, even if the lab is saying it is sensitive, how should the patient be treated?
Dr. Suryakant sir, let us know whenever you can join in. Till that time, please, you can ask your questions or we can take some questions, Dr. Singla.
Yes, yes, you can take.
So, Dr.
Madam Singla, am I audible?
Yes,
Am I audible?
Yes,
Am I
sir.
audible now?
Yes, you are audible.
Okay. Actually, Dr. Singla, this patient was treated to begin with.
Sir,
I think
आपके
from
दो devices
peripheral
एक साथ
I think
चल
100
रही
to
है.
200
So you will
kilometers
have
from
to
Lucknow.
stop one of the
This
devices.
patient reported to in the month of February.
Dr. Suryakant,
So
please.
within 3 weeks, we removed the case and we have
बंद कर दीजिए. In your room, there are probably 2 devices running together. If you close one device, we will be able to hear you, please.
The Department of Forensic Medicine, and sir, I'm here on behalf of our HOD, sir. So it's sir's daughter's wedding.
Dr. Suryakant is muted. Can you unmute him?
Say my congratulations to him and thank you.
All right, sir.
Dr. Suryakant, you're muted.
Yeah, that we have to treat the patient, not the papers. Actually, if you just review the whole story of this patient, to begin with, the all consultants who earlier treated this program, they basically dependent on all the reports. The LPA report, the AFB reports, patient was having clear-cut clinico-radiological deterioration. So this was a case when you should have taken the cognizance of clinical deterioration and radiological deterioration. And of course, there was no improvement clinically, radiologically, and even bacteriological in terms of AFB smear. So I think
We can't hear you. Dr. Suryakant, we can't hear you. Dr. Rishi, probably you can inform him that we cannot hear him.
Yeah, ma'am. Yeah, ma'am. Calling you.
And the microbiologist, and of course the various members of the drug resistance TB committee in that district or at tertiary care center for tackling these cases.
Thank you, Dr. Suryakant. Some portion of your talk we could not hear in between as the signal went off. So I think we will take the questions first and maybe then we can summarize the whole case. Dr. Amitesh, can you take the questions, please?
Yes, ma'am. There are few questions on the chat box. There is one question by Dr. Vistji. He wants to ask that when the patient sample is both sensitive to rifampicin and isoniazid, then is there any scope for doing second line LP as per the diagnostic algorithm?
You see, one is the diagnostic algorithm and one is the individual case scenarios. So whenever there is if you see the algorithm in true sense, there may not be. But whenever you find patient is deteriorating clinically, patient is deteriorating radiologically, and it's almost 2 years that he received the treatment. In such a scenario, when you find H and R are sensitive, we must do complete first-hand LPA, second-hand LPA, as well as the culture DST to know what is happening to this patient. So there is no denial to the patient that in these cases you cannot do it. It should be done.
Right, sir. Thank you. There is one more question that what type of sample is required for doing whole genome sequencing, whether it is sputum, whether it is culture, whether it is CBNet, what sample can be given?
All the samples can be subjected to this, whether it is sputum or it is the body fluids, they can be subjected to this. And what they say is that the time is reduced in case you send a smear positive case, and they also do it on the cultures to reduce the time. But otherwise, it may take 2, 3, 4 weeks, 5 weeks, because that takes time if you send the sputum or the body fluids.
These were all the questions of the chat box. I can see the hand by Dr. Alpa Dalal, ma'am. Ma'am, if you can unmute yourself.
Yeah. So, Dr. Singla, there are few cases where we have seen that the patient has got extensive cavity or a thick wall cavity. And these patients, despite of their sensitivity showing that they are sensitive to the drugs which we are giving in the regimen, and this patient continue to remain smear and culture positive. And if the cavity is limited to one part of the lung, then maybe we could consider surgical option in these patients. But sometimes there are bilateral cavities, and patients are not otherwise deteriorating, but they remain culture and smear positive. So I just wanted to know your view on this.
Oh, you are muted. Sorry, you started.
Sorry, I was muted. So, Dr. Alpa, thank you very much for your question. And Dr. Alpa is a national expert also for the DT3C clinic. Now, her question is, what about doing surgery in such cases? So, in any drug resistant case or in any case who is not responding to treatment, we must have some good chemotherapy also in hand, that whenever we plan surgery is supplemented with a good chemotherapy, that should be done. So in this case, since patient was not responding to the existing first line drugs, we have to choose how we are going to treat the patient, whether he remains drug sensitive or he is documented to be having some drug resistance. And in this case, the drug resistance which was documented was high dose fluoroquinolone on culture. Although the LPS, the first line LPS showed it is sensitive to HNR, CVNet shows it is sensitive to rifampicin. So in these cases, the dictum is whenever we have failure to treatment, say after 6 or 8 months of treatment, and in this case 2 years, we must change the treatment to the second line drugs. That is, we must treat the patient as if the patient is drug resistance TB case. So in these cases, the person is also acute resistance and high level, so he goes for longer oral drug resistance TB regimen. And in this case, the regimen could be in the group A, we will avoid fluoroquinolone, it will be bedaquiline and linezolate. From group B, we will choose cycloserine and clofazimine, and from below, we will choose the delaminate. This is irrespective of the WGS report. Because as of now, as we discussed, as of now, we may not be able to rely too much on the WGS, but good thing is that even in the WGS report, it is sensitive to the drugs which I have mentioned. So in that case, this regimen, of longer oral regimen, supplemented with surgery if possible. But as I can see the last X-rays of the March, in the last X-rays of the March, the disease is bilateral. So in that case, because disease is bilateral, the surgery will not be feasible, especially will require pneumonectomy in this case. And in a bilateral disease, the pneumonectomy will not be feasible. So once we are, also you see the X-ray, can you screen share the X-ray please? Can you screen share? Another thing I want to show in the X-ray, just please screen share. Can you hear me?
Yeah, they are doing it.
Okay.
Yeah, in those few seconds that I get, I would like to welcome Dr. Malik Parmar, who has joined us. Welcome, Dr. Malik.
Thank you so much, ma'am. It's a pleasure to be joining this meeting. Particularly, congratulations to the State TB officer and the team, Dr. Suryakant and all from Uttar Pradesh. I'm very glad to see that the UP 23C is here.
Yeah.
So the first X-ray.
Thank you.
First,
I'll come with my comments later. Thank you.
Yeah. So in this X-ray, if you see, the right side practically there is a destroyed lung, and left side, upper zone, mid zone, lower zone, there are shadows. And another thing to be noticed is trachea is very much widened. And when we see such a widening of trachea, and this is almost as wide as your vertebra. So in these cases, we should also think of something called tracheobronchomegaly. So in this case, if you do the CT scan and if you demonstrate trachea is more than 30 millimeter, then the tracheobronchomegaly that means it is definitely there. And the right main bronchus is between 20 to 24 millimeters and left is 15 to 23 millimeters. So because sometimes even this condition needs to be treated separately, they may have diverticular also once we have tracheobronchomegaly. So that is just a chance finding in this case, which is showing dilatation of the trachea, which is as wide as a vertebra. So tracheobronchomegaly should also be thought of. But otherwise, this case is not surgically operable, being a bilateral disease with right lung completely destroyed. But as with the treatment regimen we have already discussed, that should be considered in this case. And if it was surgically resectable, still we need a good chemotherapy regimen before we can think of surgery. And as per our national guidelines, at least they say 5 to 6 months of drug treatment before surgery is planned. So that also should be kept in mind.
Thank you, Dr. Singla. So going back to the...
can you share the first X-ray? Can you share the first X-ray of this patient? So
this is the first X-ray which is available with us. It is of February 2020, sir.
February 20.
Left one, sir.
So definitely, actually whole of the right lung appears to be destroyed, and there are some lesions on the left side also. And as culture and smear is positive, so we cannot think of any other thing. And I think CT has been done. What Dr. Rupak Singla was saying, that the diameter of the trachea, I think CT also has been done.
Yes, sir. This is the CT. Some of the section of CT scan.
Right.
So we need to measure the diameter
Measure,
of the
yes,
trachea.
Measure yes, of course.
If it is around 30 millimeter or more, then we can say this is a case of tracheobronchomegaly.
But Rupak, it appears that there is no doubt that this is a case of tuberculosis, first thing. And second thing, he has not responded with the treatment. And my question was, what was the clinical risk? How the clinically patient is behaving?
The patient is still having the symptoms of fever, rapid expectoration. His weight is persistently losing weight. There is no improvement in his appetite, sir. All the symptoms are present, sir.
So there are signs of activity. I think you may say clinical signs of, because fever and weight loss is two things. Because this patient will always have, because in the history you told us that he has a large amount of expectation from very beginning.
So his cultures of November and February are still positive, and we are waiting for the DSC results of the first and second line blood, sir.
Okay. I think you can ask the lab to do DST of all the first and second line.
So my query is that whether we should wait for a DST or whether we should go with the report of WGS and start the treatment for this patient, sir.
As Rupak said very rightly, you have to put on a longer oral regimen with some modification. He said very clearly, probably the primary line of drug is not going to work, and shorter regimen is not going to work as there is a fluoroquinolone resistance. So it is the all oral longer regimen he has to put and wait for the report and see that what happens. That should be the logical answer to your question.
You see, sir, in this case, again, we have to go by the culture and DST because that is still the gold standard. So we start with a longer oral regimen, and once the culture DST report comes, we can modify the regimen if required.
Yes, definitely.
Dr. Rajiv Tandon has been trying to ask the question. Dr. Rajiv.
My only question to Dr. Rupak Singla is in the integrated diagnostic and treatment algorithm for drug-resistant TB, on the right limb of that algorithm, when do we precisely label a patient as non-responder? And could it have been done at an earlier period of time in this patient?
Okay, thank you, Dr. Rajiv. You see, as far as algorithm is considered, it has not been defined exactly in the algorithm when to consider as that non-responder. But Clinically,
that is a big lacuna in this algorithm.
actually, see, these algorithms are guidelines for managing these cases. Each and every scenario, if a symptoms persist, the X-ray is not improving, even at 4 months, we should start suspecting that patient could be a non-responder. And in case we find even at 5 months, the smear is positive, culture is positive, or 6 months, so then definitely we should start thinking in terms of there is a clinical failure case. So these algorithms are just a guidance document to treat the patient, but in individual cases, we have to take the guidance from the algorithm and accordingly treat the patient.
Thank you.
Thank you, Dr. Rajiv.
Dr. Bhagirath, STU Delhi, sir. Dr. Bhagirath, sir.
Aloha, Nita, it's me, Ashwini here. I'm sitting with Bhagirath only.
Okay.
I mean, thing is, first of all, I'm not very convinced with the idea that the patient has been compliant, because somewhere it tells us you have to be very sure of the compliance. Second is, when you're having a repeated sample showing drug sensitivity to different methods, so I think we'll have to believe on it. Thirdly, I would still advise the patient should be given antitubercular therapy, admit the patient in the hospital under supervision and see the response of few days. So that will be my take. Rupak, any comments on that?
Yes, Dr. Ashwini.
Yes,
Dr. Ashwini, I agree with you in these cases. To say that patient was compliant, we must be doubly sure, because it is usually uncommon that patient is compliant and is failing, unless there are poor blood levels of this, which we have not been able to rule out. So in case we believe that patient was compliant, we should again check the blood levels of the drugs, whether patient is absorbing the drugs or not, and then combining these two information, we should take a call. And yes, in case we decide to treat with the drug resistance TB drugs, which patient will be needing, of course, we must, to ensure the compliance, we should admit the patient and give under full supervision. And once patient starts responding slightly, then only we need to discharge. Otherwise, we don't mind. We admit this patient for 2 months, 3 months also, till the patient starts responding to the new regimen. Well, after this, we have nothing in hand. Once this regimen fails, then practically becomes very, very difficult for this patient to be treated. And another question, I don't know whether Dr. Suryakant is able to join or not. Dr. Suryakant, are you there? Dr. Darshan, are you there?
Yes, sir, I am.
Darshan is there.
So you had raised another query that between BPAL, whether BPAL will be good for this patient or this all oral longer regimen. So would you like to take up that call at your level, or should I talk regarding that?
Sir, according to me, this patient should be put on the modified all oral longer regimen, sir, because BPAL is still under operational conditions and it requires stringent adverse event monitoring, sir. So it is like there is a study also in NEJM toxicities were of the tune of neuropathy of 80% and the myelosuppression was of 50%. So I think presently, because this patient is having the option of, because he hasn't been exposed to the second line drugs till now, sir. So this patient should be offered the modified all oral longer regimen, sir. So delaminate should be replaced, demoxy should be replaced with delaminate, and then the delaminate, beta-aquiline, linezolid, clobazamine and cycloserine should be the preferred regimen for this patient, sir. So any comments on that?
Yes, I think you have said the decision that in this case, since BPAL is still in a research mode and we have drugs available which patient has not taken, so we should go for the accepted regimen in the country, that is all or longer regimen with replacement of fluoroquinolone by the delaminate.
Dr. Malik and Dr. Alpa both want to say something. So Dr. Alpa, and then I'll take Dr. Malik.
Yeah, so in this patient, we've seen the X-ray and the CT scan, and right lung seems to be very badly destroyed, and cavitary lung disease. Now there are very good number of cases we see that these patients, even if you have drug levels which are maintained, the site at the local site, the drug levels, how they would be reaching is a question, because which is such a badly destroyed lung with the necrosis of the blood vessels. Many times the issue is that the drugs don't reach to these cavities. And these are the patients we see that, consistently the TST report shows that this is sensitive, but they continue to remain smear and culture positive. So there would be a big issue of drugs reaching the site. I just wanted Dr. Singla, sir, you would have seen these kind of patients. Where what's your take on this concept?
Yes, I agree with you. The thick walled cavities, it is known that the drugs may not be reaching. Even lymph nodes also, sometimes it has been seen that you're giving the drugs, the appropriate drugs, but they are not reaching. So that's a genuine concern. But at this stage, nothing much can be done in that regard because the surgical option is not there. But you have raised a very pertinent point that drugs may not be reaching in these sites. That is true.
Yeah, and we have seen in these patients, even after giving them second line treatment or third line treatment, because the issue is drug reaching the site, so they continue to fail the subsequent regimen. Also, that's what we've seen.
So in that continuity, somebody had asked that where can we get the TDM done, the therapeutic drug monitoring done? Is it being done in Mumbai?
No, we don't have. It's not being done in Mumbai.
Okay. So now I'll request Dr. Malik to ask this query. Dr. Malik. I think Dr. Malik can't hear me.
Okay, can you hear me now?
Yeah, we can hear you.
Sorry, my headphone got entangled in my mask. That's why I could kind of, it's still entangled. Okay, so thank you so much, first of all, and congratulations once again to Dr. Santosh Gupta, Dr. Suryakant, and the presenter of this particular case. Very pertinent question which has come up. This is more frequently heard from Mumbai, but now given that UP is the emerging MBR-TB hub that we know of from the national data. It's come from UP also, which warrants some discussion. So I actually concur with Dr. Rajendra Prasad and Dr. Singla as well as Dr. Ritu, who mentioned about this. Please be clear that globally also the sequencing has been recommended for surveillance purposes for want of more evidence on linking it with clinical management of the patients. So we had a discussion in November with the Mumbai team. Dr. Alpa was also there, and that with all the microbiologists, and the consensus again there was to generate more evidence with this technology, to link them, first of all, to look at the concordance with the existing available technologies on these drugs, as well as correlated with the clinical outcomes of the patients if they've been managed. So this is under research, and even globally there is no recommendation, nor has the national expert group considered using whole genome sequencing as a test for guiding clinical decisions. So that's clear. Coming to the technologies which are available, and you've used it, and I see that it's a clear case of fluoroquinolone, I would say monoresistance. Okay, because rest all the drugs that you saw are all susceptible, and given the challenge that you have already used the first line drugs, which are still available as per the DST reports, but have been exposed in the past. So the clinical committee is not considering the first line drugs, which is respectable. And hence the decision that you mentioned about the longer oral regimen is also, fairly fine. However, this patient would require much closer monitoring for adverse drug reactions, particularly you mentioned about peripheral neuropathy and all. If there is any history in the past, you need to be much more conscious about and cautious about it, and keep doing the cultures on regular basis. And based on the culture report, you must consider this patient for surgical intervention if the culture is negative at that point in time, because I can consider the point which Dr. Singla also mentioned, that yes, this needs to be considered. Talking about BPAL, the stance of the program is that yes, it has to be used in the research mode, but if you look at the national guidelines, it has given a scope that if there are patients under the program outside of those research sites, or even within those research sites where it could not be included into the research because of the exclusion criteria, etc., and there is no other option possible, like say, for example, you will be now using this 5-drug regimen that you mentioned, but if the patient does not tolerate that, I mean, let's hope not, but if that is the situation, and if you're left with a situation that you do not have adequate number of drugs, a minimum 4 drugs to start a particular regimen, that as a last resort, BPAL has been kept as an option for which you need to request CTD for provision of the courses of preterminal, provided you are in a position to maintain the necessary ethical environment required to start such a patient on treatment under programmatic setting outside of those research sites which are there currently. I'll stop here. Thank you so much once again. And it was a pleasure to be with you all.
Thank you, Dr. Malik. Thanks a lot for summarizing for the case today, because you've said it all, what is important to this case. So before I request Dr. Singla to give us the take-home message, I would just like to inform we have Dr. Ashok Bharadwaj with us, who is the chair National Task Force. So today we are joined by 15 states. We have 15 states with us. And I would also like to inform you that the movement that we started from, I would say it has rippled. The thing that we started at NIT, it has a rippled effect, and now 26 states are doing the difficult to treat TB clinic. And most of these states, I would like to inform you that 8 states have done more than 10 clinics. That's Delhi, Meghalaya, UP, Gujarat, Andhra, Tamil Nadu, Telangana, and Punjab. They have done clinics between 10 and 40. So we have some states who have done a lot of clinics. Then we have about 11 states which have done more than 5 clinics. That is West Bengal, Uttarakhand, Rajasthan, Odisha, Nagaland, Mizoram, Maharashtra, Madhya Pradesh, Karnataka, Jharkhand, and Chhattisgarh. And then we have states who have just started, who have done less than 5 clinics. That's Manipur, Kerala, Jammu Kashmir, Haryana, Goa, Bihar, and Assam. So that is the status as on date. And today we are joined by 15 states, that is Uttar Pradesh, which took the initiative of doing the clinic today. And then we have Haryana, Punjab, Madhya Pradesh, Bihar, J&K, West Bengal, Andhra Pradesh, Telangana, Jharkhand, Chhattisgarh, Pondicherry, Delhi, and Maharashtra. So that is the status for today. And now I would request Dr. Singla to...
one last question from my side. Dr. Darshan here.
Yeah, please, Dr. Darshan.
Sir, we saw that we came across that isolated F2 resistance in this patient, and I went through some literature and found that there was a study conducted at AIIMS New Delhi, in which they found that it was around 3.2% was the means they saw for the F2 resistance, and they found around 35 patients out of 1100 patients were isolated having.
Dr. Darshan, your voice is gone. Okay. So since we are short of time, Dr. Rajendra Prasad sir and Dr. Mahesh sir. Dr. Mahesh sir, you've been raising your hand for long. I'm sorry. Dr. Mahesh sir, over to you.
Good afternoon, madam. This is Dr. Mahesh, and we are facing a lot of few patient like problems, like whatever the pattern which case presented short while ago, and especially in one village, one particular village, we are getting same patients like recurrent relapse in spite of no resistance, like drug sensitive TB, but they're on and off, they're getting that positiveness. So, but unfortunately, we are not processing all those patients for genomic sequences. Just I wanted to know ask one few questions, like why that one particular villages we are getting cases like that. One thing. Second thing is, what about the therapeutic level? Like one thing which we are discussing about the therapeutic blood level. Can we able to send all those therapeutic blood level assay to NIRT or where we have to send those samples? So those two queries just I wanted to ask from you.
Thank you, Dr. Mahesh. One thing is for sure that if from a particular village you are getting cases who are, recurrent positive, first thing is we have to check the compliance and the type of DOT that is happening in these places. Why a particular geographical area has patients who are not responding to your treatment. And regarding TDM, right now, there are not many labs which are doing this, and we are not able to send samples through program, though we know that NIRT Chennai is doing it, but we are not sure how many samples they can handle. So that is something I think we will have to tie up with the program and find out what we can do. Rajendra Prasad sir, you wanted to ask a question?
But just for my clinician point of view, Darshan Bajaj, I would like to know what was the socioeconomic status of the patient and what was the literacy level. What I am asking this question, can his the answers can be relied that he said that he was all compliant. So
he is a Safai Karamchari, sir.
He is a Safai Karamchari, okay.
So the status is not very good, sir, in that sense. And he was receiving this treatment from the program itself for the last around 14 months. So as told by him that he was regular in taking the drugs and he was not having any symptoms suggestive of GI upset or some vomiting or nausea. So he was taking drugs regularly, and because
was he alcoholic? No, was he alcoholic and a smoker? What about that personal history?
Sir, we could not retrieve any history of any comorbidity also. No history of diabetes or HIV or any other immunocompromised state or anything else. There was no significant history except the first X-ray which we saw, sir.
No, I was asking about use of alcohol and tobacco use.
No, sir, he is not providing any such history, sir.
Okay.
Okay, thank you, sir.
Thank you.
And I think we would like to close the case now because we have crossed our time. So we are floating the poll simultaneously, and I will just summarize the message that we need from this, what we've learned from this case is that first and foremost, we need to see the compliance of treatment. The FDC, whatever we are giving, is it being supervised? Are our health workers taking proper history and complying to DOTS? And then we should be doing good follow-ups, that is monitoring by smear cultures, by smears and cultures. And timely, we should subject them to CBNAT whenever required. We should try to maintain the turnaround times to the least possible. And also we should suspect the failure at the earliest, and we should put them on appropriate regime at the earliest. So I think we could have done a lot if we could have followed up this case much earlier rather than waiting for 2 years to respond to this case. So if anything else, Dr. Singla, you would like to add?
I think you have said the thing. And at the same time, very, very important is the proper follow-up and timely follow-up and responding. And one person is failing, don't wait for too long. Don't wait for 2 years, even 4, 5, 6 months if patient has not responded. Yeah, then you start the appropriate regimen depending on the medicine taken by the patient and whatever lab report is available. And WGS as of today is a research tool. So yes, we should not ignore it, but at the same time, we should not take therapeutic decision based on the WGS report today. So it's a technology which is upcoming. We look forward for it, but at the same time, we should understand its limitations in India as well.
Rupak sir, there is one question from Garg sir from our side, sir.
So just from the clinician point of view, sir, since this patient has been on the programmatic condition and was receiving FDC, when we started giving treatment in program condition right from RNTCP, this point in this question has been raised as far as FDCs is concerned and versus fixed drug compliance kit. So can we think of in few patients like this, since this patient is has always been on a FDCs. The problem of intolerance is there, and problem of compliance, these FDCs were there. But we have seen as a clinician, there is a certain treatment outcome is definitely different in FDCs versus fixed drug compliance. But since program doesn't allow us to give compliance kit, so what is your take on that? Can we think that because program is very liberal now, program is open for a change, can we give these compliance kit for these type of patients, those who have a history of say intolerance, or many times these issues they crop up with patient, and many extra pulmonary patient also we see when we put these patient on compliance kit, these patients respond. So as a clinician, so your take on that, because you are much more experienced than me.
Okay, Dr. Ajivkar, thank you so much. If you remember, for years together, India was using individual tablets, not the FDCs. So we waited too long, and then once we were convinced that the FDCs which we are using in our country, they have the good blood levels of this, the bioavailability was ensured, only then the Indian government switched to the FDC tablets. So in that case, we should have faith in this because they are tested for their bioavailability before they come to the market. Yes, in dual cases where there is ADR, suppose there is an adverse reaction of hepatitis. In that case, definitely we will not be able to give the FDC. We will be giving the individual tablets depending on how much dose you want to give for INH or rifampicin, as we are serially introducing these drugs. So there, the role of individual drugs may be there, but otherwise, the drugs which are there in the market through the government, the bioavailability has been assured. So that faith we should be having, and we should be using FDC supplied by the government. And whatever other things are there in the market, yes, that is challengeable. And we have seen that many times, even from good companies, the FDCs which are there in the market, they are not giving us the proper bioavailability. The multiple published studies are also there. So that is my take on this question.
Yeah.
Thank you, sir.
Yeah, thank you. Dr. Malik has raised his hand.
Am I audible?
Yeah, you're audible.
Right, thank you. One last and very important point I would like to emphasize here. This case that we discussed is a clear, bacteriologically confirmed drug-resistant TB case, right? The national guidelines are very clear, except for probable MDR TB in children, which has a clear definition and a way of defining it. In adults, the concept of clinically diagnosed MDR TB patient does not exist in the guideline. Okay, we have to be very clear that if we have to consider a patient as drug resistant, we need to have a clear bacteriological confirmation of drug resistance from a NTEP certified laboratory. Please take this message very clear and loud. Thank you.
Yes, Dr. Malik, I agree with you, but even the program allows that cases who have taken treatment for 5-6 months or more and are not responding, so declare them as clinical failure cases and put them on the drug resistance TB regimen. They are not labeled as drug resistance TB, but in those cases, we are putting them on drug resistance TB regimen, those who have not responded to treatment after 6 to 8 months of regimen. So that also we need to keep in mind. So program allows them to be treated.
Yeah. Sir, that's exactly the reason why the difficult to treat TB clinics have been established, and thanks to your leadership in this as well. These cases have to run through the difficult to treat TB clinic for decision making. Let's be clear, it's not an open permission to all the DRTB centers at the district and the nodal level to take this decision. It has to come through the district and the nodal DRTB. Sorry, it has to come through the state and the national difficult to treat TB clinic. And based on the guidance of the experts, after a thorough expert consultation, regimens have to be decided accordingly. And it has to be also notified to the program accordingly. Thank you. Thank you, sir.
Yeah, thank you, Dr. Malik. I would also just like to announce that we have NatCon this year, which is being conducted by Dr. Jaikishan at Ambala from 11th to 13th of April. So we request everybody to participate in the conference. Dr. Jaikishan, would you like to say something?
Jaikishan, unmute yourself.
You are cordially invited for this 76th NetCon at Institute of Medical Sciences, Malana, Ambala. And with the help of these national experts and everyone, we are able to have a good scientific program. We are going to have 9 workshops, and the workshops are of the new titles, even the Cochrane's view, even the bronchial artery embolization, the role of these ultrasound in chest practice, and all the National Institute, the National Institute of TB and Respiratory Disease Delhi, NIRT Chennai, NTI Bangalore, and Jalma Agra, and the DRTB, and everybody is participating. And you will hear whatever the new strategies with the NTEP to end TB by 2025. And we will have a good academic feast. And the Northern India are famous for this. Otherwise, the feast also. So you will enjoy both the things together. So please block your dates, April 11th, 12th, and 13th, and most welcome for that. And I will give you this website, that is NetCon. That is there or here. So you can join this. Thank you.
Thank you. Thank you, sir. With this, we end today's clinic. Thank you, UP team. Thank you, STO sir, Deputy STO sir, Dr. Suryakant sir, and all others who have taken efforts to present the case today. Thanks a lot. And thank you all the participants for attending. Do we have Dr. Ashok with us? Yeah, Dr. Ashok, over to you for your closing remarks.
So thank you, Dr. Nita, for giving me a chance. It was a wonderful discussion today. And before I say anything, I must say that we must follow the guidelines as stipulated by Central TV Division, Government of India. So I personally request Dr. Rupak and Dr. Malik that we should go fast towards launching of PPAL once the result come. So as Dr. Nita told, there were 15 states, but I could see Himachal also. She did not name Himachal, but I could see STDC Dharampur in Himachal Pradesh. So you can see Nita here that most of the DTO they are missing here because we are going through an exercise pan India, that is sub-national certification of TB-free districts. So all DTOs are engaged in that activities. So they are the medical college faculty, they are after their head, they are having, they're requiring many information from BTOs, and they are busy in that. So otherwise we could have reached more than 500 participants in this meeting. So congratulate team Uttar Pradesh under the dynamic leadership of Dr. Suryakant, Dr. Bajaj and his team. And a wonderful presentation by Dr. Meenakshi, and the whole of Uttar Pradesh team has become a dynamic team. So I must compliment and congratulate Dr. Santosh Gupta for this purpose. So in many issues, many other activities of National TV Television Program, they are progressing fast. That is the first state where each one of the medical college, they are adopting orphan pediatric patients. So it was the endeavor, the vision of their Honorable Governor Madam Anandi Banerjee to have this activity in Uttar Pradesh, and hope the country will also follow them. So thank you, Dr. Nita, for giving me a chance, and thank you all the participants for joining out of their busy schedule. Thank you very much.
Thank you, sir, and thank you everybody for joining. Thanks a lot.